I am Dr. Peter Kagaba. I work with Makerere University, and sometimes I put patients to sleep, usually while they're having some brain surgery things. So my task or my job this evening would be to talk about neuromuscular blockade and quantitative monitoring of neuromuscular transmission, and somewhere along the way introduce you to sugammadex. So this is essentially what we shall be discussing. And I hope at the end of the talk, you will have a deeper understanding of these issues. However, before we go on, I hope everyone here has got an Android phone. Yes? Or an iPhone. Even the guys online, I hope they are following. So pull out your phones, load some data, and let's start. Residual neuromuscular blockade is actually quite common. And just like Mary has demonstrated, it is under-recognized. So even though she thinks it is small, it's actually quite big, somewhere between 24 to 64%, depending on which source you read and how it is measured. But on this hill, it is up to 33%. Okay. So probably about a third or more than a third, probably more than a third, okay? And I will explain why. Of your patients will end up with residual neuromuscular blockade. And you know, what we normally do is use clinical signs, like whether the patient is raising their head, whether they're following instructions, like they can give you a good hand grip. But these are reliable, rather unreliable, okay, as we will see as we go on. So this was done by Emedu in some of the PACUs on this hill. And he used raw acceleromyography on patients who are arriving in the PACU. That is after they have already, given a muscle relax, rather a reversal agent, extubated, and then brought to the PACU. And what he found is that 1 in every 3 patients had residual neuromuscular blockade. He also found that there was a 36.5% incidence of acute respiratory events. And these are things like mild hypoxia or airway obstruction. Now, why did I say it's probably more? The way he measured it, okay, he used an acceleromeograph, which usually requires what is called a normalized train of 4 ratio. And I don't know if Emiedu is around or if he's online, but he will tell you that he didn't take a baseline train of 4 ratio and then use that to measure every other measurement that he took for each of his patients. And usually what happens with the acceleromeogram, it actually gives you a train of 4 ratio of greater than 1 at the baseline for some reason that can't be fully explained, but maybe because acceleromeograms just measure the force, or they equate the force of the movement of the thumb to the amplitude of displacement. You know that Newton's law of motion, force is equal to ma. So the acceleration of the thumb is proportional to the force that is generated by the thumb. And that's what's actually used to tell you whether there is return or to measure the function of the muscle. But it has these inherent problems with it, and it tends to overestimate. So when you use that to tell you whether you have residual neuromuscular blockade, you actually will say for most of your patients that they have hit the threshold for saying there is no, or that there is no residual blockade, or that they have acceptable recovery, and yet they may actually still have residual blockade. So most likely we have got more than 33% of our patients. Now, the RECITE study, this was done in Canada. before some of the guidelines changed. And for them, what they discovered was that at extubation, and this is before transfer to the PACU, 63% of their patients had residual neuromuscular blockade. And when they arrived in the PACU, they had 56. So there was time from when the reversal agent was given to when they arrive in the PACU. So there is the neostigmine or whatever reversal agent they have used reaching its peak effect, as well as spontaneous recovery. So you can see that difference in the amount of residual blockade. So some patients have recovered to the point that they have an acceptable level of recovery. So if you look back at Emilio's study, that tells you also that because he measured this in the PACU, what actually we would have found at extubation would be even higher. Okay. Now these people used a normalized train of 4 ratio. Okay. So we can believe that this high amount is actually real. So that's just measuring how many people have residual neuromuscular blockade. We haven't even talked about the complications. Okay. So when we give patients these drugs, we need to be able to tell how deep they are. Okay, there is a consensus on how we can describe and how we can measure depth of blockade. Okay, so if you use qualitative methods such as a peripheral nerve stimulator and observed and a subjective observation of what is happening. Okay, does my patient have a train of 4? No. What about do they now have a post-tetanic count, right? And then if they have a post-tetanic count, sorry, if they have a train of 4 ratio, then how many, sorry, if they have a train of 4 count, okay, how many do they have out of 4? And is there fate? Okay, so they are, the levels are, if you, I think everyone can see the table up there, right? Maybe a bit blurry, but so on the first column, you will see the block depth, and then we have got the qualitative methods of monitoring that uses a peripheral nerve stimulator. So you can measure the train of 4 count, okay, with a peripheral nerve stimulator. And if your train of 4 count is 0, then you check for a post-tetanic count, okay? For those who don't know what a post-tetanic count is, what happens is you give a 5-second burst of stimulus, okay? And then you wait 3 seconds, and then you give a twitch, okay? And you then, it will give about 20 twitches, okay? And then you see what the response is, and you will count, okay, how many twitches you see, okay? So first, you check for a train of 4, okay? So that means the machine delivers 4 stimulus, okay, at a frequency of 2 hertz, okay? 1, 2, 3, 4. Now you check for the response. Usually we use the adductor pollicis brevis. So if you don't have anything there, that's 0, no response, then you do a post-tetanic count. And if you check your post-tetanic count and it is 0, then we call that complete blockade. That means we're saying more than 75%, usually close to 100% of all your acetylcholine receptors are occupied by the antagonist that you're using. Okay. Now, if, however, you have a post-tetanic count of 1 or more, but no train of 4 count, then we call that deep blockade, right? And when you finally get return of some muscular function, then we call that moderate. And we're talking about a train of 4 count of between 1 to 3. Okay. So when you have a train of 4 count or a train of 4 response, we don't do a post-tetanic count. Okay. It's pointless. It doesn't add any value. Right. So 1 to 3, that is moderate. If you have 4 responses, then you also look for fade, okay? So when you're using a qualitative monitor, like a peripheral nerve stimulator, this is about a subjective observation, okay, for whether there is a decrease in the amplitude from the first twitch to the fourth twitch. Okay? All right. So if you have 4 twitches with fade, we'll classify that as shallow. Okay. If you have 4 with no noticeable fade, okay, then we would classify that as minimal. Now, notice here that for if you are using a peripheral nerve stimulator, okay, and you're just using either tactile sensation or sight, okay, you're looking at the patient's thumb, or if you're using the facial nerve, you're looking at the orbicularis oculi, then once the train of 4 ratio drops below 0.4, okay, 0.4 to about 0.6, you will be unable to tell that there's actually fade, okay? If, however, you have got a quantitative monitor, you will still be able to detect this difference in neuromuscular transmission, okay? So you will notice here that at the point where you have no fade, the patient's train of 4 ratio could be anywhere between 0.4 to 0.9. Now, most of you would be convinced if you saw this, that your patient has no residue blockade, but that's not true, okay? So that just tells you that beyond this point, the human being is unable to tell that difference. So we are unable, using the qualitative method, to determine whether our patient has got acceptable recovery. And so you will see here, we don't even grade it in that category. While for the quantitative monitor, okay, the grades are going to be, for the way we look at it, is still going to be the same. The difference here is that once a patient gets to the point where we can't appreciate that there is fade, we are still able to tell. Okay, so if we go back a bit, if you use if you're quantitative, what these monitors really do is they will first do a train of 4 count. If the train of 4 count is 0, then it will do a post-tetanic count, okay? But depending on the monitor you use, some monitors you actually have to manually start the post-tetanic count, okay? So it will check, you will start it, and it will do the post-tetanic, it will do the train of 4 count, it will return a 0, and then it will wait for you to start the post-tetanic count, right? Now, if you check and it is 0, like we said before, you grade as complete block, okay? If it returns a count of 1 or more, okay, then that is going to be deep block. The moment you begin to get a response on your train of 4 ratio, then we move to either moderate or shallow, okay, depending on what you get, okay. If it's 1 to 3 counts, then that is moderate. If it's 4, okay, then the machine will now return a ratio, okay. Understand that the ratio is the height or the amplitude of the 4th twitch to the first twitch, okay? So if there is no 4th twitch, the machine doesn't give you a ratio. Instead, it gives you a count, okay? So at this point, for a shallow block, the ratio would be between 0.1 to 0.3, okay? Some machines will return a percentage, okay? So this would be 10% to 30%, all right? And it's just an indication of how much of the receptors are not occupied by the muscle relaxant, okay? So, and so on and so forth, right? So this is what happens as you give your patient a muscle relaxant, okay? And you will move through these stages, okay? Now, depending on where you put the electrodes to monitor whatever you're doing, you may have the patient progress very quickly to the point where you have a train of 4 count of 0, okay, and therefore you may decide to intubate. So at induction, we normally you can use the corrugator supercili, or you could use, even the orbicularis oculi should be all right. Now, the corrugator supercili usually is very resistant and will mimic the sensitivity of the diaphragm to the muscle relaxant that you're using. So if you are aiming for a patient who's, you want them not breathing and you want their larynx completely paralyzed, then you can use that as your indication for your endpoint when you can intubate, okay? So what I haven't said here is that the larynx also has the same resistance as the diaphragm, all right? So we've already talked about the stages here. That's just a demonstration of what happens. So at the end of surgery, of course, or towards the end of the period that your patient has had the drug, you begin to get return of function. Now we say your patient has acceptable recovery when you have a train of 4 ratio of 0.9. Remember, you can't do this without a quantitative monitor, okay? So if you are unable to tell that your patient has reached 0.9, you're then uncertain and you don't know whether to extubate that patient safely. So you will notice from what I have said previously that there's a difference in response that you get with different muscles. Okay, there's a difference in sensitivity. On the right here, or sorry, on the left of that diagram, you will see that as you progress down, there is a decreased sensitivity to the, sorry, not decreased sensitivity, but rapid response, okay, for the rate of onset of the muscle relaxants, okay, with the more central muscles and the muscles with the higher blood supply responding faster to the drug, okay, and the more peripheral muscles responding later, okay. And one of the reasons why we use the adductor pollicis brevis is because it's sort of mimics the sensitivity of the muscles that we would like to make sure that there is return, okay? And we're not really concerned about the patient's ventilatory effort. No, we are more concerned with the integrity of the lungs, the ability to protect the airway. So we want to make sure that that has returned before we can extubate the patient, okay? Yeah, so we've seen that there's already variability in the way these drugs affect different muscles, okay? But there is also other things in play here, okay? So you will notice that for a drug like rocuronium, if you give 2 times the effective dose, okay? And what I mean here is the dose that will cause 95% decrease in the twitch, okay? There are going to be different factors that will affect it. For example, it's going to be faster in younger patients, faster in females, and also if you have primed the line, if you give it rapidly, okay, and if you, for example, giving it along with ephedrine. If you use a smaller, it's going to slow it down, okay? It's going to slow down the onset. And then the duration is also unpredictable, okay? Prolonged age, older age, all right, female sex, okay, pregnancy, all right, patients who are on drugs like anti-epileptic drugs, those may actually recover faster from drugs like rocuronium. So there is a wide variability, and it may be difficult sometimes to predict the response from your patients, how much they may need, when they may need to be redosed, okay, and when they will recover. This is why quantitative monitoring needs to be used. So we've already, or at this point, you should have realized that you are unable to tell whether your patient has made an adequate recovery from the drug you have given, and that a lot of these patients go unnoticed. Okay, so why should this matter? Okay, and the reason is that they're both physiological and psychological consequences of residual neuromuscular blockade. Patients in the recovery, when you talk to them later, they may tell you that it took long for me to wake up. I felt very weak. I felt sleepy, but sometimes that's because of the weakness. Okay, the muscles, they can't open their eyes. Okay, they feel really sluggish. Okay, and it may just simply be because of the muscle relaxant you gave them. Okay, but that may be trivial. The more serious problems are adverse respiratory events. Okay, these, although rare, are serious. Okay, and there are studies that have shown that for severe airway adverse airway events, just having severe residual neuromuscular blockade in the vacuum increases the chances of getting these problems. All right. And then the other problem is that for most of us, we may not even see the complications that these patients suffer because we have given them these drugs. This may be on the ward, okay, or a week later because of a pneumonia, right? So while the complications are rare, they are serious and will be costly for the patient. This is the RECITE study, which is the one done in Canada, and the popular one that both showed that there is increased complications when you have residual neuromuscular blockade. So what can we do? The most important thing here has to do with monitoring, okay? And because we have seen that qualitative monitoring is not optimal, okay? It's not sufficient for us to improve the safety for our patients. So I think at this point, I don't think I have defined what residual neuromuscular blockade is, but historically, it was defined as a ratio, train of fall ratio of less than 0.7. But a couple of years ago, well, more than a couple of years ago, they discovered that there was a higher incidence of patients with residual neuromuscular blockade, even when they had a train, sorry, not a higher incidence, but a higher rate of complications, okay, of patients who met the criteria for not having residual neuromuscular blockade. Okay, and these patients were usually between a train of fall ratio of 0.7 to 0.9. So the threshold was moved higher up. Okay, so currently we define residual neuromuscular blockade as a train of fall ratio of 0.9, of less than 0.9. Okay. Yeah. So the classic tests that we normally use at the bedside, like whether the patient lifts their head, a good hand grip, all right, and whether they can move out their tongue, okay, or a tongue depressor, these are not good enough, okay, and they miss 70 to 90% of patients with residual neuromuscular blockade. Now, for people like me who are stuck with a peripheral nerve stimulator, this is subjective, okay? And mostly what I rely on is a train of four count and a post-tetanic count, okay? But it is still subjective, right? And while it may reduce the number of patients that I might have with residual neuromuscular blockade, it still leaves me with almost 50% of the patients ending up with residual neuromuscular blockade. So, I mean, what you can take home from this is that we still need quantitative methods of monitoring. So this is what I use. I'm better than you. you don't use anything, really. However, this is still not good enough, okay? All you can do here is do a train of 4, okay? You can do tetany, you can give a 50 hertz here stimulus for about 5 seconds, then you can do a post-tetany count by pressing the twitch button there. What you see here is where the stimulation or the electrodes are over the ulnar nerve, all right? When you have colored leads, usually it's the red up here and the black down here. It has something to do with what is called cathodal stimulation, but that is beyond the scope of this talk. So the point here is to stimulate this muscle, okay, the adductor pollicis brevis. Yes, so I think we already talked about it. There are other sites that you can monitor, and I think I have a slide somewhere we talk about sites. Yeah, so this is an acceleromeiogram, okay, or myography. What you have here are the stimulating electrodes. The arrangement is the same as with the previous slide that I showed you. And up here is the motion sensor. So this senses the acceleration, and that, like we talked about, Newton's second law, force is equal to mass times acceleration. So the acceleration is proportional to the force generated by the thumb, okay? And that's measured using a piezoelectric crystal. Yeah, this is still not good enough. Rather, this is better than the PNS method. However, like I had said earlier, it tends to give a train of 4 ratio of greater than 1. Okay, now that shouldn't be happening, because what you're doing is comparing the last twitch to the first twitch. Okay, so at baseline that should be 100%, or that should be 1. But this monitor sometimes gives you, or usually actually will give you, a ratio of about 1.2 to maybe even 1.4. So if you're going to use 0.9 as your threshold for saying the patient has made acceptable recovery, you realize that 0.9 is not going to be the actual. You're still going to get a lot of patients who are truly below 0.9. So what is done is what is called a normalized ratio, right? So you get the baseline, and if it's 1.2, you will write that down somewhere, right? So any other ratio you get is measured over that, okay? You divide that ratio that you get over the 1.5, right? And that's times 100. That's what you call a normalized train of 4 ratio, right? So if you have your calculators, you can try that out, and you will realize that to get what would actually be 0.9 would probably be about 1.2 if you had maybe 1.4, okay? Yeah, so that's important. If you have an acceleromeiogram, like the one Emiedu had, I don't know if he still has it, but that one, the count that it gives you would have to be treated in that manner. Unless, of course, you've got a machine that automatically does that, okay? The newer machines, once you start it, it will take the baseline, and then that's what you use. And then it will give you, and you don't have to worry about doing a normalized ratio. So this is better than the PNS, but if you understand the problems that I just talked about, then this is also perfect. Then, of course, this is what would be ideal, the electromyography. This one measures the evoked potential. It measures the compound muscle action potential. So you have electrodes, stimulating electrodes over here, okay? Again, over the ulnar nerve. This is just a ground electrode, okay? Then you have got the recording electrodes over here, okay? This one is placed over the muscle. That's the one that actually records. This is just a reference, okay? Yeah, so this records the electrical signal in the muscle, not the actual muscular movement. And this is considered superior to the EMG. You don't need to do a baseline for this one. You can just start straight away. Places like Nakasero have got this. So if Nakasero has it, then Dr. Mark, we will soon get one here, right? So it's way. Excellent. So you can see here, it has done a train of 4 count, okay, and you can see the response here is 4, right, and it has given the train of 4 ratio. Of course, this one it has done so in the form of percentage, right? So there are other modalities that can be used. There is the kinemyography, okay. This one uses a piezoelectric sensor which is placed on the thumb, like you can see there, and then on the index finger, and the distortion of the muscle causes contraction, and that again, the force of the contraction is what is measured and then transduced as your responses, and then you get a training for ratio. Okay, it has got problems, and it's notoriously imprecise, so I wouldn't recommend it. On the left over there is the TOF cuff, which is a compressor myography, right? It's what happens is the electrodes here are just attached to the BP cuff, and it monitors the response of the muscle to stimulation. It has problems, okay, and really what happens is it's just stimulating the brachial plexus nerves and then monitoring the contractions in the upper arm. It's not very reliable. So I don't know if you will see any of these around. The most popular ones are the accelerometer and then the EMG. Yeah, in terms of the quantitative monitors. So regarding monitoring sites, what you have mostly seen is the ulnar nerve, which is the gold standard. And the reason is because we are more interested in the adductor pollicis brevis muscle. And that's because it closely approximates response or return of function to the pharyngeal muscles. The facial nerve can be misleading, okay? And the reason here is that because you have got the corrugator supercilii, which sometimes may be stimulated by your sensors, and yet what you're really interested in is the orbicularis oculi. So if you see the superciliar, the corrugator supercilius, that one is as resistant as the diaphragm. And the diaphragm, you can get return even with moderate blockade, okay? So patients start to breathe, and if you're using your end-tidal CO2, you will give some more drug. Or if you want to extubate, you will think, oh, my patient has arrived. We are done. Let me take the tube out. But that's deceptive, okay? Remember, the diaphragm is very resistant and returns a lot earlier. So if you're using that, then unless your desire is to get a really deep block, okay, then you can use the corrugator superciliary. All right, so we talked about how common this problem is and how under-recognized it is. We've also talked about the best way to monitor it. So now the next thing is, when do we reverse our neuromuscular blockade? Any answers? Pardon? Mary? Confirm that there are no correlation if you have. All right. So for you, you would reverse when the train of ratio is more than 0.5. Yes? Yeah. So, but yeah. So a strategy is required for us to manage our neuromuscular blockade as part of our anesthetic technique. And by now, you must agree with me that the only way to go about this is with a quantitative monitor, right? And so these monitors do several things. One, they tell you the depth of the block, all right? So if there is a desired target, you have a surgeon who wants absolutely no movement, all right, then maybe you're going to be thinking, I want a profound block, a complete block. And with your nerve stimulator and your quantitative monitor, you will be able to tell that and decide when to dose and not to redose unnecessarily. You will also be able to tell how much to give, okay? And you'd also be able to tell when you can safely reverse the blockade. So there are a couple of agents that are used here for reversal. Neostigmine, which I think to date is the only one we use in this country. And now we are seeing sugammadex, right? So this is newer around the world, but it's been around for some time. However, the patent for sugammadex has, I think, lapsed, I think, in 2023. So now we are probably going to see more of these on the market, probably become cheaper and more available everywhere. That has problems, which we shall talk about later. But so neostigmine, which we mostly use, has got a couple of problems. But the biggest one is that it's unpredictable, it is slower, and it has got a ceiling effect, right? Once you have given the drug, you can't really expect to get more once you have reached the peak effect. Giving more doesn't achieve anything. In fact, you may actually get a paradoxical blockade. Did you know that? Okay, clap for yourselves. All right. So with neostigmine, I don't know if it's terrible, but dosing for neostigmine, if you have got a peripheral nerve stimulator and you have a train of four count of 0 to 1, okay? Notice we haven't even talked about having a PTC of any amount, okay? It's pointless to use neostigmine if you have got a complete block. It doesn't help you at all. Okay, that means train of four count of 0, right? Just wait for spontaneous recovery. So when you get to a train of four count of between 2 to 3, you could then dose it at 50 mics per kg, but I would advise you to wait about 30 minutes, okay, before you even extubate, right? The reason here is that you don't have a quantitative neuromuscular monitor. So all you don't have much information on whether your patient has achieved an acceptable level of recovery. If you have a train of four count of 4, okay, with fed, then you can use 0.4, which is 0.04, so 40 mics per kilo. If you have no noticeable fed, then you can do 30 mics per kilo. If you are like Dr. Agnes and you have got a quantitative neuromuscular monitor, you are then able to tell uh, different grades beyond minimal blockade. Okay, so if you have a train of 4 ratio of greater than 9, you don't have to give the neostigmine. You can simply extubate. If, however, you have a train of 4 ratio of less than 0.9, but more than 0.4, then 30 mics per kilo should be sufficient, and then you can extubate 10 minutes later. If, however, your train of 4 count is 2 to 3, or your ratio is less than 0.4, then you use a higher dose, 50 mics, and it may be prudent to wait 15 to maybe even 30 minutes before you extubate. Okay, remember, neostigmine is slower onset, all right, and time to reach its peak effect. You have to be careful with neostigmine sometimes. You don't see its peak effect immediately. So the assumption that, oh, my patient has recovered because they're now moving may be detrimental for the patient because later on they may lapse back. Okay, that's one of the problems with neostigmine. Now, how about sugammadex? So there are those who think that with the advent of sugammadex, we don't need quantitative neuromuscular monitors, but that's not true, because sugammadex also gives its best responses when it is titrated to the effect that you desire or to the amount of drug that is still running through the patient's system. So if you have a peripheral nerve stimulator, what you will notice here, the difference here with sugammadex is that you can reverse even a profound, rather even a deep block, okay? So you will see that for a train of 4 count of 0, okay, over here, and a post-tetanic count of 0, that's what we would call as a complete block, although you are not encouraged to use it at this point, but you can reverse a complete block, okay? So this is like your, let's say your patient who's coming for a thyroid, difficult airway, you give them the muscle relaxant, you fail to put the tube in, you now want the patient, you want to reverse your muscle relaxant. At that point, let's say maybe 3 minutes after you've given it, you can give sugammadex, but you need to give a big dose, okay? So 16 milligrams per kilo. That means, do you have the required amount in your hospital? Okay. So it's not simply that, oh, we can reverse this. You need to have the drug available. But also remember, you might reverse you might get return of neuromuscular transmission, but that doesn't take away the effects of any propofol or halothane or isoflurane that you have given, okay? You may still have to manage that airway. Anyhow, so if you have a deep block, okay, which is a train of 4 count of 1 to a post-tetanic count of 1, you can use 4 milligrams per kilo, okay? And if you have a train of 4 count of 2 to 4, 2 milligrams per kilo should be fine, right? And usually you can extubate rapidly for most of these patients, like within about 5 or 10 minutes, you can extubate, okay? If you have a quantitative neuromuscular monitor, then you are doing much better than these chaps over here. You can, more objectively measure your patient's level of blockade and decide whether to give or not to give, but the dosage will depend on the depth of blockade, okay? Yes, maybe just to go back on something I just said about the 5 to 10 minute extubation, you're probably better off waiting 10 minutes, okay? Because you still need to check that your patient has reached adequate recovery, right? So 0.9 and above, and then you can extubate, but the time is usually shorter for sugammadex than it is with neostigmine. So now that we have arrived at sugammadex, we shall talk a bit more about it. So this is what sugammadex looks like. It is the only selective reversal agent for neuromuscular drugs. Okay, it was created mostly with rocuronium in mind. However, it can also be used with vecuronium. Okay, so that structure you see there is a modified gamma cyclodextrin with those 8 side chains which contain negatively charged carboxyl groups, right? And there's a deep hydrophobic cavity in there that enhances binding of rocuronium. So essentially, it acts like a sleeve, okay? That is the molecule, your muscle relaxant, okay? And that is the sugammadex molecule. And this is what happens when you give your patient sugammadex. It binds and takes the rocuronium, vecuronium out of circulation, okay? Reversal is usually within 2 to 3 minutes. Don't forget, the dosage depends on the degree of blockade, okay? Yeah, so there's a bit of evidence out there that shows when you use Gammadex compared to neostigmine, you have almost a 30 to 40% relative risk reduction in pulmonary complications. Okay, there's a couple of papers out there, popular, stronger, and the both. These are mostly observational studies. So it's safer to extubate with Gammadex. However, it is not innocent. Okay, there are some issues that have come up with it, especially since the lapse of its patent. It's now being used more widely, and so there are more reports coming in about different uh, uh, about different issues. Okay, now part of the problem here is that extubation is a high stress period. Okay, your patient may be coughing because they're now getting lighter, so there may be tachy's, all sorts of things are happening. They may have bronchospasms or laryngospasms, and sometimes people may think, okay, maybe this patient is having an anaphylactic reaction, maybe related to the drug given the patient. So there are all sorts of reports coming in. But what some of the studies have shown, especially in places like Japan, Japan doesn't have recovery areas. The patients leave the operating room and go straight to the ward. That means their practice is such that by the time they let you leave the OR, you are recovered. And so they do everything to make sure that recovery will be very rapid. So this is a drug that they have adopted wholesale. And so there's quite a bit of data coming out of there. And what they have found is that about maybe 1 in 5,000 people you may see an anaphylactic reaction from the pair of Rokironia Sugammadex. Okay, but otherwise, most of the other reports show that while these risks are there, they're not as common as we think. Okay, it's mostly the individual reports that sort of heighten people's anxiety and make people think that these things actually exist, but they don't. Okay, however, you should warn your patients who take oral contraceptives about needing supplemental contraception in the 7 days following exposure to Rokironia. Okay, wait. Sorry, Sugammadex, not Rokironia. Okay, so yeah, there are those issues, and then of course, you need to look out or have a high index of suspicion for serious hypersensitivity. And if your patient has hypersensitivity to Rokironia, then you should probably avoid. Sorry, yes, even if they have a high sensitivity to Rokironia, you may still want to avoid giving them Sugammadex. Okay. Yeah. So the clinical strategy here is monitor and decide the dose, all right? And then monitor again and decide when to reverse. And before you extubate, confirm the train of 4, okay? This is a proposed strategy by some chaps who wrote an article in the BJA, in analgesia and anesthesia. This, I don't think anyone can see this clearly, so maybe I will skip over it. Has it become bigger there? Pardon? A bit. Getting better. All right. All right. So 15 minutes before you start. All right. Pardon? I said 15. 15 minutes before planned extubation. Okay. 15, 1, 5. Elizabeth, you are getting close to my age. You can't also see. So, so 1, 5, 15 minutes before planned extubation, okay, you do your train of 4 ratio, okay, and if the machine gives you a number, okay, a ratio in this case, and it is less than 0.9, then we are not extubating, right? The question now is simply, are they still doing the procedure? Okay, they are. Then let's just continue to wait. If they're not doing the procedure, then we're still waiting for spontaneous recovery. If you, sorry, let's go back a bit. You do your train of 4 ratio, right? And if you get a ratio of less than 0.9, then you can't extubate, right? You need to reverse, all right? Yeah. So then it is a question of what have I got, okay? If that train of 4 ratio is less than 0.4, right, then you're going to, if you've got neostigmine, you're going to dose it appropriately. If you've got sugammadex, you're going to dose it appropriately, right? And once you've given it, then there is the requisite amount of time you may have to wait. If you have got a quantitative monitor, of course, you can monitor, and once you get to 0.9 and above, then you take out that tube, all right? However, if you don't have, if your count here, sorry, if your ratio is greater than 0.9, then of course you can straight away extubate, right? Yeah. Here, the only advantage you will see here is that with Squamadex, it is more reliable in terms of predicting when you can extubate. But neostigmine, even when you have a train of 4 ratio of 0.4 and above, okay, but less than 0.9, and then you give the neostigmine, you may see varied responses, okay? 10 minutes later, you might still have a train of 4 ratio of less than 0.9. And that's the problem with neostigmine. Yeah, that it's not very predictable in terms of responses. But anyhow, that is if you have got a quantitative monitor. For most of us, all we have is our good sense between our ears, and if we're lucky, a peripheral nerve stimulator. So that means we must then find ways to get these monitors into our operating theaters, okay? And on top of that, we must then ask for better agents for reversal, okay? If you want to reduce the risk of post-op residual neuromuscular blockade, you need a quantitative monitor, okay? And you also need better drugs. I would say cisatracuria, because it's more predictable than ROC. But you can't use a drug like sugammadex with cisatracuria, okay? So what you decide to do will depend on what you can get and what you have, okay? But if you have got a drug like sugammadex, then you're happy using a drug like ROC or vecuronium, right? If you don't have a drug like sugammadex or you don't have access to it, then you need to think again about what to do. But a drug like cisatracuria is gives you faster recovery than ROC, okay? And that's because its hydrolysis happens, yes, by Hoffman's degradation, and is not dependent on your patient's renal or hepatic physiology. So people like Dr. Mark need to be sat down and convinced to give us these monitors and these drugs, right? And then, of course, there are training gaps. A lot of us, a lot of us don't have the necessary knowledge or skill to use these monitors and to use them appropriately. But these things have got benefits, right? They may not be readily apparent to some of us. I mean, you may think that as an experienced anesthesia provider, I mean, my patients are fine, okay? They don't have these problems. Okay. And that's largely because in the period that we see our patients, we don't have to deal with these problems. You know that the incidence of adverse respiratory events is 1% or less. Okay. Of course, depending on where you practice, uh, it may be higher in some places, but the general thing is that they're few. Okay. They're few. But they are serious when when they happen, and if they happen, they are not good for the patient. Okay, but then there are also complications that we don't see. Okay, because our patients are with us for a short time, we never see them the following day or the following. So we have no idea what impact we have on this patient's quality of life after surgery. Then we need people like Dr. Nampina to champion these things and push for procurement. So as I come to the end, this is how I usually do it when I can. Okay. Um, for most of my patients, everyone gets reversed. Whether I think the recovery has been adequate or not, I will check with the nerve stimulator. All right. And depending on what I see, I will then adjust my dose of neostigmine and also when I extubate. Right. In general, I prefer to wait until my patients have got a train of 4 count of 4 with no visible fade. Those ones I know I can give the neostigmine now, and 5 or 10 minutes later, I can take that tube out. Okay. But again, I'm still not sure whether they have reached full recovery. That's just because it is what it is, and that's what I have got. Okay. Yes. But ideally, I would like to have a train of 4 ratio monitor like Dr. Agnes. so I guess we should all aim for this uh, at the end of the day. So if you don't remember anything, okay, at least remember that we need to be using acceleromyography and electromyography for our patients. And only when we have a train of 4 ratio of greater than 0.9 should we extubate, okay? We need to reverse intelligently, all right? The dose needs to be dependent on what the depth of the block is, and we need to allow time for peak effect, okay? Even with Sugamadex, okay? Yeah. Otherwise, Sugamadex is probably the more predictable of the two reversal agents. Thank you. Questions?
I think we can clap better than that. It's a life-saving topic. It's like examination. And also it is every decade of practice and it's heavily discussed it. So that's the points. And I think what it didn't tell us is the person who supplied it. But you can also get hooked up on that guy, who's that guy. Maybe some microphone discussion, the presentation, Mr. Sanjay. Do you want to tell us how much this will cost us? Shall we send only the kidneys? Sanjay Kumar, applicant for books for some know me, but some faces. So it is our seventh product. If we talk about cost, it is 65,000. Hospital.
How much is in the vial? That's what you're asking. In milligrams, in milligrams.
200 mg.
Yeah, the usual dose is between 2 to 4 milligrams per kilo. So if you are 70 kilos, that is as little as 140, okay, or as much as 280. Pardon? So one ampule is probably enough for probably one patient. Yeah.
I think I have given, it is a dosing chart is there in the PPT.
Yeah, so I already talked about the dosing charts.
Okay.
So I mean, we can go, I can open that other one as well. Let me see if I can find it.
So this is the dosing chart. You can calculate. Even we have for Android. For iPhones, we are developing Android with the app, groups on the app, where we have all the products and where the patient and the dose will automatically. We will share the link.
Agree.
Agree.
Any other questions?
Anyone with a very good question, Dr. Aga, you can as well just complete the section. Bit of more explanation based on settlements. Patients who are who undergo neurosurgery, they need to be extubated when they are still deep. The FDA said that as therapy set, and they're expected to reverse patients very fast. Thank you.
Yeah. You can reverse deep blocks, okay, with stigmatics. That's the unique thing about it compared to neostigma. You just have to give an appropriate dose. That's the main thing. Because if you want to reverse like 30 minutes after you've given your muscle relaxant, then you're going to need 16 milligrams per kilo. That's a lot. Uh, so that's the problem. But for someone who has a moderate blockade, then you just need 4 milligrams per kilo. Okay? So if the surgery stops now and your patient has like a 24 count of 1, you can give the sugammadex and then check maybe 10 minutes later and then extubate. Yeah. Okay. And deep anesthesia. Okay. And deep extubation or deep anesthesia. So this depth that we're talking about, the depth that we're talking about here has to do with the degree of neuromuscular transmission antagonism. Okay, not the level of anesthesia. Okay, so after you give the sugammadex, okay, the gas might still be going, okay, or whatever propofol you're giving, that means your patient is still going to be hypnotized, okay. They will not be awake or aware, but neuromuscular function will have returned, okay. Yes, that means the diaphragm may be moving, okay. Yeah, I hope that clears that. So it yes, I think that's it. So with sugammadex, you don't worry about bradycardia. You don't, because what happens with the with neostigmine? Neostigmine is an acetylcholinesterase inhibitor. Okay, so it inhibits the enzyme that breaks down acetylcholine. Acetylcholine is the molecule that binds to the receptors on the postsynaptic end plate and then causes depolarization of the muscle, and so the muscle contracts. That means if you want to send a signal to the muscle to contract, you can do so if that receptor is free and you have got acetylcholine. Okay, but when you get a muscle relaxant, that muscle relaxant, if it is something like rocuronium, it sits, okay, either in the acetylcholine receptor or even in the channel, and prevents that channel from allowing ions in, and therefore prevents depolarization of the muscle. So any signals you send down there will not be heard. There will be no response. Okay. Now, when you want to reverse the block, you give neostigmine. Neostigmine prevents acetylcholine from being broken down, and therefore increases the amount of acetylcholine in that junction, okay? And that outcompetes the muscle relaxant. And so the muscle relaxant is displaced from the receptor. Now, if you give neostigmine at a point when there is a huge load of muscle relaxant, okay, it doesn't matter how much neostigmine you give, there will never be enough acetylcholine to displace the muscle relaxant. That is why the time when you give it is important. Because if you give it too early, then the body, the natural or the spontaneous recovery hasn't happened. The body hasn't broken down the drug and eliminated it. There is still a huge amount of the drug at the neuromuscular junction. And so the acetylcholine does not have a competitive advantage. You may see a transient response. Patient wakes up, they lift their head, maybe they squeeze your hand, and then you think, oh, I have reversed. Let's take the T-bar, let's take recovery. But in recovery, the patient, as you said, goes back, okay? So that is why it is crucial for you to monitor the patient, because at a certain point in time, giving neostigmine is pointless, okay? It's pointless. Yes. I hope that answers your question. Yeah, but once you give Sugamadex, it works. There's nothing like duration of action, okay? There are some people, well, I've seen some papers that question whether there is some kind of recularization, but I haven't seen anything convincing, okay?
Sufficient for now. Very much teaching. In case we reverse with Sugamadex, and for any reason we need to relax again, and I give a higher dose of Procronia.
That's an interesting question. Most times, what are you going to relapse with? Because you can just choose another drug, like cisatrachyrium or SARS. But I don't know. That's something to think about.
Why there is communication between the two. I think it can be a scenario in my kind of situation. Sometimes you get patients with BPH. Then do the surgery, you go back, then they tell you, I think they're having an atmosphere. The scans and they tell you have fluids inside, and you suspect you need to go back to jail. So in that short duration, you run back to the table, the previous reverse your Sugamadex, I mean your Rocuronium Sugamadex. Do you reload with Rocuronium or do you switch it up?
Sorry,
Maybe the duration.
You-
How safe is it?
you're going to have to repeat the question. I wasn't paying attention.
Okay. His question was, you reversed with Sugamadex. In the event that you have to go back to the table, would it be okay to use Rocuronium? So how soon would you need to use Rocuronium after getting Sugamadex?
Well,
As a muscle relaxant?
I think if you have a quantitative monitor, then that should be an easy problem to solve, because all you have to do is give the rock and see the effect. But if you don't have, or probably even the peripheral nerve stimulator would help. If you don't have, then you risk probably giving too much, I suppose. But it may just be simpler to use another drug. Yeah. Dr. Agnes says something.
More questions, comments?
I was just thinking, did we discuss that? How them
In the body.
for them to answer this question?
Yeah. Unfortunately, I don't have that answer. I can't tell you that.
Any more questions? Thank you. So you've been referring to Agnes's machine. What specification? Can you give me the specs? To date. That you're using, not stimulating yourself, that you prefer. So, you don't think this machine available.
Yeah. So when I refer to Dr. Agnes's machine, what I'm referring to is a GE monitor, really, that has got an integrated quantitative neuromuscular transmission monitor. And what it actually uses is an EMG. Okay. So, but these are add-ons that you can get for most monitors. Even the monitors we have down there, the Infinity Delta, you can get either as a separate standalone that you just add to it, but there should also be a way to upgrade the monitors to get an empty monitor.
Let me ask a silly question. What is the difference between the peripheral nerve stimulator and this thing?
Yeah.
Because that's the spec that's clearly
Yeah.
stated.
So the difference with the peripheral nerve stimulator is that that's all it is. It's a peripheral nerve stimulator. You attach the stimulator electrodes to the nerve you intend to stimulate, and then it will deliver the stimulus that you require. It has got options for you want to do a train of four, rather count, rather you want to do a train of four, you want to do double burst stimulation, you want to do a single twitch, you want to give tetany at 50 hertz or 100 hertz. That's it. It doesn't monitor for the response. Okay. The quantitative monitors are able to measure the response. Okay. They're able to tell whether there was a response. Okay. And then they can even give you the ratio. Okay. The ratio of the fourth twitch to the last twitch. And this is objective. You don't have to depend on a 40-year-old who can't see the hand moving or who can't feel the hand moving. Okay. That's the difference.
Therefore, if I look for a machine that can give a ratio, am I in a better position to purchase an equipment that will,
Yes,
or
it has to be. I mean, for if you, in terms of asking for what you want, what you have to say is we need a machine that can do quantitative neuromuscular monitoring. Which community?
the business
Then it's our job to educate them.
this audience is wrong. So, seriously, the issue of the ratio is something that will be indicated on the monitor itself.
Yes, it should be evident that the machine can do a train for ratio. Yeah.
Just online, there is the initial half-life of gametics of 2 hours, but the drug remains active. I mean, it remains in active mineralization associated with the like bonds, teeth for 7, 8 days.
Yeah, it's partly why you also worry for people who use contraceptives. You don't take them, then there's a increased risk you will get pregnant.
So most studies, the other question will be probably to it's very big sponsor study in the black and the fluorescent setting. We should very fast. Try obstetrics, not the information that's very advantage the Japanese colleagues have for the good stuff. Dr. Mark, that's quite that's the quantitative.
There are a couple of questions online. So Ronald is asking, should those without quantitative monitoring stay away from gametics? I don't think so. That's the simple answer. The other question here is, what do you do in case of an overdose of gametics? Well, good question. I will look that up and let you know. You can't use rogue in 24 hours after gametics. So this is Mary Juliet who's telling us. She's probably an experienced user of gametics. Yeah, the big dose. But the other dose, you should be all right. Yeah. Yeah. All right. Yeah. I don't know if there is such a thing as an overdose of gametics, but we'll find out. I think what you have to remember for most of these, you're using the lean body weight for, especially for the muscle relaxants. You use lean body weight. I think that's all the questions online. Agree.
Peter, are you taking hands?
Okay.
Yes, Fred has something he wants to say. Fred, go ahead.
Hi, thank you, Peter, for your presentation. I just happened accidentally to be in an institution.
The institution doesn't have network. Fred, we can't hear you. Fred, just type your question in the chat. He's abroad. I don't think he can come. Okay, I think Fred will type in his comments. You can try. You have a lot of money. WhatsApp call, I think, might be the best thing to do. It doesn't seem to be around. He said I'm in an institution that has Sugamadex. There's no institution in Uganda that has Sugamadex. At least as I'm, well, there is some in UHI. I saw some in UHI. You have a vial, which is expired. So Cure Uganda has. So then Ronald should tell us
in the country have a new natural because you saw here this Spanish. Yeah, but your sound here is not that much for the microphone.
Agava is here. You talk to him.
I can't. Fred, sorry, I didn't catch that. Hello? Fred. I didn't hear what you said. Are you able to text? You're driving. Okay. Well, he seemed to be saying something important, but we lost him. Okay. Yes.
This drug is available in pure channels.
This particular one that you guys apply?
Yes.
Oh,
It's available. Soon is
all
available.
right. All right. So that's okay. All right. So that's what Ronald was saying here, that you guys have it. Okay.
And second, Dr. Agri is asking that can we sponsor a research on sugamatics? Yeah, we can. If somebody is interested, we can sponsor, and if anybody
Yeah, but you just make sure that you're adding to the point you've loaded. Not doing something that someone else has done.
That will supervise you.
Okay. That's a gentleman over there.
Yes. Presentation is what I done with students. Complete. The question is sugar index absolutely contraindicated in patients with renal failure? Can I give it safely to patients who are candidates maybe for dialysis? Then the second one is it also safe for the first trial youngster pregnant mothers?
Ronald can field the question on renal failure. Maybe. I don't know if he can speak. Ronald probably can't speak. Pardon?
Yes, what's the question?
So
Dr.
the
Agava?
question for patients who have renal failure, is
Yeah.
sugammadex contraindicated? Absolutely contraindicated? And is
No,
it?
not absolute.
Yes. You have your
There are
answer. I
different
think.
levels of renal failure.
Yeah.
But use with caution.
Use with caution.
Since it's eliminated renally, so it's like it grabs the sugammadex grabs the molecules of rocuronium, and then they are taken through the kidneys and they are washed out. So that's the challenge with renal failure patients.
And then which first trimester, is this very safe to use?
You should ask the obstetric anesthesiologist.
Asking you, you're the only one who has experience in Uganda.
I don't
So
work with pregnant mothers. Sorry.
regarding pregnant women, I think you'd have to talk to Alfred or Chino. But the main, the big or the serious contraindications for sugammadex are for really
Working.
the others are relative or questionable. Okay. Yeah. I think so. This is what's probably going to happen because since its innovation and introduction into practice, it has been under a patent. Okay, and so the cost has been very high. Okay, he says 65K, but 65K is still high. Okay, for us now, imagine how much higher it was. Okay, so but gradually that cost is likely to come down. And that means that the number of people using it is going to go up. Okay, so we are going to see more reports coming in about problems with the drug, whether they are real or imagined, we shall see them. And then the studies will go out to see, okay, whether these things are actually real. So some of the questions you have right now may not be able to, they may not answer them now because a lot of things are in evolution. Okay.
Yes.
Yeah.
I was just trying to answer his question of group. It's so that is why it's a bit controlled. You can end up and so it's discouraged using pregnancy. So it poses a question. If you want to you have to just wait until you have
Well, luckily for you, you have got neostigmine. You can also use it. Pardon?
Yeah. Any more questions?
Okay. Agree.
Once again, we need to give Dr. a big clap. The other big clap is going to be Mr. Sanjeev for bringing this wonderful drug to you. After this, we are heading out for dinner outside. It's going to be perfect. But I've been reminded by the president that on the 27th, there is a and the kits cost 100,000. Please contact Faith for the kits, but we are all encouraged to participate in the solidarity run. We increase awareness about anesthesia. Most people know about the surgery. But forget that there is, before you get surgery, there's CCN officer for your safety. And then they continue seeing you after. Then probably they continue seeing you in the ICU. So I think we need to increase our visibility. Let everyone tweet about it. Let everyone talk about it. Please TikTok about it. So X about it. Let everyone know that we are happening, we are being there. Invite a friend, tell a friend, invite a friend, tell an enemy as well, and let them come that day. Thank you so much.
For the people online, they're wondering, is there a code they can send to Javas and get delivered?
We shall give them their behalf. Sanjeev, is there the code?
yeah, you take from Phil and you have to go there. Get good.
All right, goodbye, guys. Online, we're going to eat. See you.
Thank you.
All right. Thanks, everyone.